All right, good. Now it's afternoon. Good afternoon, everyone. Welcome to today's event. My name is Craig Thompson. I'm the Channel Marketing Manager here at Wavelink, and thank you very much for joining today's event, our Critical Communications in Critical Care Units, a live panel discussion where we are bringing together people from the coalface that are currently experiencing the global pandemic. Now, before we get started, there's a few housekeeping rules that we just want to outline for today's event. For anyone wanting to ask a question throughout the event, we'll be having a Q&A session following the main panel. So you can either enter your question in the questions panel, you can chat to me directly, or you can raise your hand and we'll unmute you and you can ask a question to the panel directly. We've also included some handouts for you to download and take with you following the session. You'll find those in the handouts tab, and they'll also be included on a follow-up email you'll get tomorrow as well. We are recording the session, and again, the session link will be provided to you in an email tomorrow. If you do have any issues with the audio at the moment, we suggest you check your audio settings in the audio tab, and if there are any further issues, you can chat to myself directly by contacting the Wavelink organizer in the chat box. With that being said, I'll now hand over to Alan Stocker, a health practice lead at Wavelink and moderator for today's event. Enjoy, everyone, and I'll come back to you later to facilitate the Q&A. Thanks so much. Over to you, Alan.
Thank you, Craig, and hello and good afternoon, everyone. Thank you for joining. I know that you're all especially busy, especially those of you that are joining from, we've got a wide list of hospitals across the country that are joined today, so thank you very much. I'd like to start by setting the scene for today's conversation. Many healthcare providers in Australia are embarking on a strategy of how to address critical communications. Critical communications inside a hospital isn't a new requirement. It's existed for years, and different technologies have been used to address this, whether that's portable phones, pagers, overhead paging. When I visit hospitals, I see a whole utility belt of devices being used. The requirement of having a better way to communicate in high pressure environments has existed for some time, and COVID-19 has highlighted the fact in many environments we need to be better prepared. Today, we're joined by two of our customers, ACT Health and the Royal Melbourne Hospital, who have invested in smart device technology from Spectralink and adopted a strategy for mobile communications within their hospitals. I guess the point of today is to outline of how having a communication strategy has enabled them to address the requirements of communications in their critical care units within their facilities. COVID has certainly accelerated these strategies, but the requirement will stay the same long after COVID. We will also be joined today by Spectralink, who will provide some insights into how hospitals in the US are dealing with these communication challenges. So before I introduce you into our panel, I just want to show you a short 2-minute video clip from the 60 Minutes TV program, which just highlights some of the pressures faced by the Royal Melbourne Hospital under the COVID-19 pandemic.
Tragically, this has been the deadliest week of the pandemic so far in Australia. But for many of us, it's still difficult to fully comprehend the true extent of this disease. So tonight, the grim reality of what goes on in Melbourne's coronavirus wards. We're taking you right into the highly dangerous red zone at the Royal Melbourne Hospital, where extraordinary battles are being waged day and night. On one side, extremely brave doctors and nurses fighting to save the lives of their patients. On the other, the enemy, COVID-19. You're looking at a place you never want to see in real life. In the war against coronavirus, this is the front line. It's called the Red Zone.
There is a bit going on at the moment.
Short for Respiratory Emergency Department.
How far are they?
This is Victoria's oldest hospital, the Royal Melbourne.
And COVID unknown?
And for more than a century, it's never seen anything like this.
Her breathing rate has increased. My COVID positive patient in bed 2 is trying to leave.
For the first time, they've agreed to allow cameras in
Partner's also COVID positive but has been cleared.
to capture the confronting reality of this pandemic.
We're going to refer her to intensive care. It's an awful disease. There's no two ways about it. Every day we're seeing young people die.
And the danger here is obvious. Everyone must be covered head to toe in PPE, with COVID-19 literally floating in the air.
Today we've had lots of patients with coronavirus rolling in. It doesn't stop. No. They just, the moment that you think you're just going to have a quiet day is the moment you know you're just going to have a busy day. So you just can't relax.
Okay, thank you for that. Now I'd like to introduce you into our panel. So first off, we have Sarah Worboys, who is the Digital Patient Flow Program Manager at ACT Health. Good afternoon, Sarah. Welcome.
Good afternoon.
We have Emma McDonald, also from ACT Health, the Senior Project Manager. Afternoon, Emma.
Hi, Alan.
And we have Sean O'Donnell from the Royal Melbourne Hospital, who's the EMR Project Manager. Hi, Sean.
Hi, Alan.
And from the US, we have Bill Foster from Spectralink, who's the Director of the Healthcare Business Development. Good evening, Bill.
Good evening, Alan, or good afternoon to you. Appreciate it being here.
Thank you very much for joining in your evening. All right, guys. Well, I'm going to kick off with the first discussion topic. So health providers in the US market are quite matured in their mobility strategies. In some ways, it's a bit of a crystal ball for us in Australia as to what to expect in the future in healthcare settings. Bill, can you provide us with an insight into how mobility in healthcare settings has developed over the years in the US?
Sure, Alan, and it's interesting you say crystal ball because in the U.S. with 7,000 acute care hospitals, some of them are in the dark ages and some of them are leading the way with the newest technologies. So certainly it runs the full spectrum. But if you think about 10 years ago when smartphones got introduced, it really changed the game. I mean, before just having a mobile phone was great because now you have the ability to perhaps talk to that patient. Patient might press their pillow speaker and want to talk to their nurse, and that you'd have that capability. And that was game changing. Well, now with smartphones and the ability to have applications and a whole ecosystem of solutions within a hospital that can all interact with each other, it really has changed the game. But you also have to develop a true mobility strategy around that, because you don't want your technology to get in the way of your workflows. We're there to help your workflows, not inhibit those workflows. So whether it becomes patient medication or dealing with alarms and alerts or dealing with just simple communication, that's really what you need to look at when you're developing that mobile strategy. So at Spectralink, when we work with customers here in the US, is looking at what are those drivers? Right now, as you point out with COVID, obviously a driver is certainly, safe and healthy of the staff, safety and healthy of the patient, and everybody within the organization. But at the same time, I look at it, we have to look at your mobile device is a device that is for communication, talking and texting. It's for notification, those alarms and alerts. And it's for documentation through your electronic medical records. So those are the kind of conversations that we have with customers.
And in the US, what does clinical messaging look like? I mean, if I walk into a hospital as a doctor or nurse, what tools am I allowed to use to message, another colleague?
Sure. When first, you had smartphones come out, and all of a sudden everybody starts doing, little instant texting back and forth to each other. And so there's a little law here in the U.S. that things have to be, patient safe. It's HIPAA. It has to be HIPAA compliant, and HIPAA is the Health Insurance and Portability and Accountability Act that basically protects patient information. So you have to have a device that can send and receive messages, but is HIPAA compliant. In other words, it doesn't contain, or if it contains patient information, it doesn't stay on the device itself, sort of stays in the cloud, if you will. So you have to be careful that somebody else doesn't just pick up that phone and is able to read patient information that could be sensitive. So one of the things that we have to make sure we have is, a robust messaging system that can not only be HIPAA compliant, but also make sure that the right message gets to the right person or the right group of persons so that it is actionable.
And that's called secure messaging in the US, I understand, and that runs on multiple smart devices and desktops. How many hospitals in the US are using secure messaging?
Oh, wow, probably good 80% right now. It's just one of those things that's just really taken off. And particularly when you have, a pandemic going on where you may not want to have the capability, or you may not be able to have the capability of having a face-to-face conversation with another clinician or another provider. So now you have the ability to text back and forth. And now there's even some applications that have come out that are HIPAA compliant, where the clinician can communicate with family members who are not able to visit the patient or visit the family member, and they're outside the hospital, but you can still provide updates, videos, pictures to that patient, or the patient's family outside of the hospital.
That's fantastic. Now I know that Spectralink is doing a lot of work with these secure messaging providers, but can you maybe share with us, some of the work Spectralink's doing with other key players in the health industry, EMR vendors, etc.?
Sure, that's actually my role here at Spectralink, because I'm responsible for the interoperability of our device with the ecosystem of partners that we have. And some of them you might be familiar with are your EMR vendors like Cerner, and Epic, and Meditech, and Allscripts. But we also have interoperability with the nurse call providers and the patient monitoring providers like Philips and GE, Mindray, Neon Coden. We also have integration with the various, what we call clinical communication and collaboration partners. So those clinical communication collaboration partners are the ones that provide that middleware, if you will, of communication that allows messaging and alarms to take place between different systems within the hospital. So Spoke, or I don't know all the ones that are in Australia, but Vocera, even Cerner has CareWare Connect, and Imprivata for your one sign. A nurse only has to sign on once. I know that nurses may have to sign into 3, 4, 5 different applications, and it can be kind of cumbersome. But having a middleware provider like Imprivata, that you just either scan your badge or you just enter your password and it logs you into all of them. Very, very handy.
Thanks, Bill. I'd like to open up now and change the topic slightly and hear from ACT and Royal Melbourne. Guys, you both recently went through a process of setting a strategy of mobility at your facilities. And I'd like you guys to sort of outline what you went through. And could I start with Emma and Sarah? Could you share that with us?
Oh, no worries. So here at ACT Health, we set out on the strategy to transform how we do communication in the hospital. So the current hospital is a very manual process. We do use pages and a vast number of phone calls to communicate within the hospital. The beginning of our adventure with the clinical smart devices was, if you've got a pager, you get a device. But as we've been going through this journey, we've really started to see the vision around that mobility strategy and around, who's the right role that requires the right device to get the right messaging. So we're actively going through that process at the moment. It is a new process for our hospital, understanding the roles from a communications perspective. Plus, we're also going through with our wards people having the Spectralink devices at the moment, and they've got multiple benefits that have been realised on the day that they were launched, with the efficiency of work that they've been doing with primarily our patient transfers. But with the messaging around critical codes and test results, I might hand to Emma. So from a ex-nurse's perspective and a project manager to really talk about how we're doing that strategy here.
Thanks, Sarah. It's definitely been a change since I started working for ACT Health over a decade ago, and I actually started in Royal Melbourne. It was interesting watching that video and seeing a few faces I knew. So we definitely rely on our paging system, which is very one-way, very basic. So as we've been talking to people in our workspace, they're actually looking at ways they can do things differently in the future. So instead of just a, yes, everyone's going to get a critical code, it's, well, you don't actually need to get it because you got it before, doesn't mean you need it now. So we can actually do a much more targeted approach. So we wanted to have a single device that would get all that messaging in instead of having multiple different devices. And as we've been speaking to the areas, they're starting to think about how that could actually work for them. And they're coming up with ideas that we hadn't thought of originally, which has been really positive. Then having critical test result notification coming to the same device as well, but also setting us up for our digital health record in the future, which is coming in a couple of years. We're really setting the base now of how people are going to use different devices so that we're future-proofing ourselves.
Alan, just one thing I didn't mention was with COVID-19, you know, I think for everybody, critical communications has been brought to the forefront of everyone's minds. I think it's always been on everyone's minds around how we do critical communications. For us at ACT Health, one thing that we really noticed is the benefit of that push-to-talk functionality. So where we have nurses and doctors in the red zone or the green zone, being able to communicate outside those zones without affecting their PPE and their donning and doffing of that. So that was also, the devices have been very well received and used during this pandemic for us.
That's right, and noting that ACT Health has been very lucky. In ACT, we don't have any cases currently. We've done a lot of preparation, but they've actually been using the devices for any of our isolated patients. So not COVID necessarily, but similar ideas with any of our isolated patients.
So essentially, you've got the platform today. You mentioned you're using it for push-to-talk, paging, messaging, voice, critical test results. And you've you've invested in a platform that's ready for your EMR later on. Sean, that's a little bit different for you guys because your strategy, your EMR is recently rolled out with Epic. And can you talk about your strategy? Because initially you looked at the devices. I think the main use case was all around the EMR as part of the precinct rollout, and then on top of that you had a requirement to add in voice, so that you weren't just using the device as a data capture device.
That's correct, Alan. So our strategy was more about enabling the nurses in their workflows at bedside. So more about having a device that runs Epic Rover. We've just successfully pushed Epic across 4 major hospitals in Victoria, the Royal Melbourne, the Royal Women's, Peter Mac Cancer Centre and the Children's. So we now all run on the same EMR. The concept behind it is that we have an application inside Epic called Rover, and that creates all the workflows for the clinicians as they're at bedside to scan medications, to do all sorts of things. It is seen as a platform where we want to add additional functionality in the future. As Alan said, moving to having a voice on the phone was very crucial in choosing the device, and to be able to expand the capabilities of it. We only went live with Epic on the 8th of August, so less than a month ago, and we've had no significant technical issues at all with any of the equipment that we've put in. But what we have seen, and we, as you saw in the video, we are very stretched at the moment with COVID-19. We are definitely in the thick of it, being in that northern part of Melbourne. And we have NED and RED, which is respiratory ED and non-respiratory ED. We have ICU. We have a whole heap of COVID wards, which are starting to decrease their requirements. But as those wards became very hot and we had the products going in there, we actually saw a change in a lot of the activities that we were doing with the devices. So even simple little things like being able to configure across the fleet that when a nurse goes and scans medications, by the time they go into the isolation unit and get a double scanning, it was timing out. So the ability to use the Spectralink application manager to change across the fleet, that it now has a 30-minute timeout, was a massive bonus. So we keep finding these different bonuses and effects and different ways that people are using the devices, especially in heavily COVID areas.
Thanks, Sean. And I guess that really leads me into sort of the next question that I've got for the group, is something I get asked a lot, and you guys are best placed to answer this, is what made you guys go out for a purpose-built device, in this case, the Versity? Why didn't you look at consumer smartphones? If I'll start with perhaps with Emma and Sarah.
Yeah. Yeah, they just went up to it basically. So I love going out and doing demos for this, and I'm talking to clinicians who are going through multiple phones a week. They're breaking things constantly, and I drop it on the floor, pick it up, and I keep talking, and they slightly freak out until they realise that no, this is actually going to be better for them. So they really wanted that robustness of the device, the capacity for us to use the GRS function of it in the future, and the scanning and the camera. It was just the whole package for us.
Yeah, and also that durability is really key. So we're finding, especially with our community nursing and our support staff within the hospitals, traditional, smartphones, we've all broken a screen. Their rate of breakage is quite high. So there's a high expense there to continuously replace devices that are being smashed. So having, we've got 150 devices with our wards people at the moment, and which, some people call them orderlies. Look, they get thrown, they get dropped in bathrooms. They, to date, we haven't had any phones break. So we've had a few user error issues, which we're always going to have that. But when it comes to the durability, we haven't had any complaints as yet on that.
Sorry, Kirsten.
I was just going to say the other key thing for us is around that infection capability, where we can wipe it down with the clinical grade wipes. Those wipes don't kill the screen, which is a really big advantage, especially now within a pandemic, but also moving forward. I think that behaviour of wiping phones down is going to be increased within our hospitals.
What about how you manage charging all those large number of devices, and what do people do when the device is running out of battery power?
So we've got the first rollout of the devices. The larger rollout of devices are planned over the next few months. We've been doing some prep work for those devices, and we are putting in charging stations within each ward, so that there are shelving units or that are in a specific location where all the charging stations are. Every user that has a clinical work device will have a second battery. So if a battery is running flat, they can just go pick up a new battery, click it in, and off they go. So that hot swappable battery has really made it easier to not have a huge bank of devices on charge at any one point in time.
Sean, what about from a Royal Melbourne perspective? Why Versity? What sets it apart for you guys?
I guess one of the simplest things, and having written a spec in the ACT for theirs as well, and just having to come to Melbourne and get another 600 devices here as well. I guess it's the antimicrobial plastics. It's cleanable with Cleanel wipes. Ours get scrubbed with Cleanel wipes 10 to 15 times a day, and it doesn't affect the device at all, except for when the nurses put little stickers on them. Really, the device is indestructible. Its charging stations are very rugged. They fit in nicely. You've got the spare batteries behind it. This time, the implementation this time was a lot simpler. We found that users, especially the clinicians, were easily adaptable to the device. It wasn't complex because it doesn't look like a another type of phone, it actually looks like a mobile phone. They were really adapting to that. The technology of barcode scanning was crucial for us as well. The ability to do lens grid and actually have a grid that comes up on your cameras to be able to do wound care. There are just a plethora of advantages that we're seeing in all different aspects. Community care is different from acute care. ICU is different from ED. And we're seeing general wards are operating in a completely different function. And it's interesting to see how each use case, and I do call them use cases, we document it as we understand how they do their processes. And it really does enable us better to understand what each ward does as far as connecting to a bed call system for alerts. We're using Teams in some areas for workflows. And again, it's all very rudimentary stuff at the moment, but it will continue to grow the more that we understand the functionality.
And I remember when I first came to your emergency department, of course, they've got all of these devices now running on their Wi-Fi network. And one of the key requirements for them was clear voice communication between the users. It's something that they were really struggling with. And how do they find that now, Sean?
Look, there is no issues. The only black spot we had was a Wi-Fi black spot. We haven't had any phones that we hadn't had any calls over the last month that calls can't be made or anything to do with the hardware. User uptake has been very, very strong, and there's been a few little user errors, as Sarah said, with their sample in Canberra. But really and truly, the people are adapting to these devices so easily.
And you've got people using them, of course, in ICUs, in areas where they're donned up with PPE. I presume they're wearing gloves. How do they find using the device while they're actually wearing gloves? Are they still able to interact with it?
Well, as you probably remember, Alan, in the ACT, we did a lot of testing on that during the evaluation phase, and we found it to be, far superior to the other products. We have had a couple of little questions from some of the clinicians here that, especially in the radiation areas, that they are struggling a little bit with it. We're looking at, and it hasn't appeared before or probably after COVID, but we are looking at styluses and other things that we can give the clinicians that will give them greater flexibility, not only to use their hands, but a pen as well.
Yeah, thank you. And I guess opening up to everyone, what devices have we replaced in the facilities? So what devices I've talked about the utility belt, but what devices were you using to communicate before you had the versities in place? I'll direct that to Sarah and Emma.
So within ACT Health, we would have clinicians walking around our wards. They will have their private mobile phone. They would have maybe 1, 2, up to 3 pages, depending on what roles they are in for that day. Some other clinicians will also have I62s that have been used throughout the organisation. We're looking at replacing a lot of those devices. So we will be replacing the paging system and the non-duress I62 devices. And the second phase of the project will be to replace the duress devices that are being used in some of those high care areas.
So essentially, it's enabling people just to have one device as opposed to carrying multiple to do their role.
But fundamentally, the biggest requirement that we've received from all our users within the hospital is, I just want to carry one device to do my job, to do everything. So we've also looked at what other apps can go on the device from to assist with some of those clinical areas. So, NIM, some of those more traditional apps that can go on the device, and that's been received well as well.
So Bill mentioned earlier on about the imprivator and the tap and sign in. So walk me through, if I'm a nurse at ACT Health and I walk into my ward, how do I know which device is mine? How do I know which one to pick up?
Doesn't matter. It doesn't matter. So there will be some staff that have an allocated device, and that's theirs. They can take that home, they can use it for work and also out of hours. And then the vast majority of the fleet that we're implementing will be shared devices. So when I start my shift for the day, I will come in, I will tap my device with my Improvato, so my ID tag, and off I'll go for the day with that device. So it doesn't matter. We're developing in-house a roles app where we can actually identify, today I have 2 key roles, these are what my roles are, and that is on the device, so anyone can contact me at any point in time.
And have you found that the staff find them easy to interact with?
So far we have, yes. We only have a small group of clinicians currently using them, but over the next few months as we roll out the devices more broadly, but the appetite is there. So as Emma was saying, the multiple discussions we have with the wards and the clinicians, they just want them and they want them on board quite quickly. So we're working towards that now.
Yeah. Sean, obviously in your environment, you're dealing with the brunt of COVID. I'm sure infection control is a hot topic. How are you keeping the devices cleaned? Is there a list of agents that you're allowed to use to clean the devices? What's sort of like the protocol you have to go through with the phones?
So we have a standard protocol. Normal phones or other things when they go into hot zones have to be put into bags. The Spectralinks, because they are allocated to a unit/ward, stay inside. If it's allocated to a specific room, such as an ICU bed, then it's actually allocated to that person. So when they come and take on a shift, they go swap out the battery and then they go sit in their cubicle. And that phone could be either used inside. We've been using it for a bit of video conferencing for patients who are passing, and also for family conferences, because we can't have that many people in the room, and in fact there's very few access into the rooms from loved ones, so we're finding the device is able to suffice for video conferencing, teleconferencing family members into the room.
And your environment's a bit different to ACT, so you're not using them as shared, I understand. Perhaps can you just walk me through, if I walk into RMH, how do I know which device?
It is a similar strategy. Unfortunately, we didn't get a kiosk mode on top of it, so when you do select this product, make sure you do choose an appropriate MDM, and again, do that by, Sarah's nodding, choose the right MDM, because it really does make a difference on how the product functions. Ours looks like an Android device, as you can see on the connected health image. It does look like Android. They can move things around, and we do display the icons on there. We've actually published the name of the device using Spectralink Application Manager. So we actually expose the device name. So up in the top bar where you've got your utilities up the top where battery and everything are, it actually has a little icon up there that Spectralink give us that allows us to put in the name of the device. And there are 4 titles that we can use as a description. So in most of it, it'll say 7B nurse 1 to 10. And when the nurse goes and picks it up, they'll look at the number on it now. It take a little bit of time for them to find where that is. And it also says the SIP extension as well, so the telephone number on the phone. So when they pick it up, they know that's the phone that they've got for the day, and it's allocated to them. We also have an in-charge phone which has 4G, similar strategy to what was in ACT, where the in-charge takes that phone throughout the day. If they're on the campus, so anywhere in the precinct, the Wi-Fi interconnects. But if they go off-site across to one of the other buildings, that in-between trip is covered by 4G.
Thanks for that. And interesting. Go ahead.
Alan, I was just going to also just add, Sean also mentioned a really good point around clinicians going through different sites. So we will be implementing So geofencing. So if you have a device and it leaves the geofence area or the area that we've identified, then the device will be breached. So we're using that as a security mechanism, especially once we start using the devices for our EMR. So that if we do have wandering devices, we can ensure that the content doesn't get stored on the phone. They're within the apps. However, it is that extra security barrier to keep that information contained.
And you've done that within your MDM. So you've got, in this case, SOTI, which is an MDM that supports that geofencing capability. Yeah. Okay, well, I'm going to move on now to the next topic. And this is around the high pressure settings, such as emergency department and ICU. I want to ask you, how did you find having a purpose-built smart device as opposed to something like a pager help you build a response to enable your teams to have improved communications in place? And I'll direct that to Emma first.
So we have used them in a limited fashion at the moment in the ED and ICU because we don't have our full implementation ready yet. But ICU have been using them for that push-to-talk function that Sarah mentioned earlier. They love them, absolutely love them. Yeah, so we're a little bit limited on what we've done so far. I would suspect that Sean would have a lot more to say than we can.
So yeah, you've had to prepare, I guess, for COVID. You haven't had to live it as much as Sean, but I guess really understanding from you, what steps have you had to take in terms of your communication devices to prepare those for those environments?
So to prepare for some of those environments, we've been looking at how we set up different channels. So we push to talk, we want to contain some of the broadcasts that we do within that function. So something that we're looking at working with our ED at the moment is around, ED's fast paced, it's quick moving, each minute counts. So how do we get that communication to the right person, but also without broadcasting it to the whole ward or the whole ED space? So we are working with ED staff at the moment around, okay, we have different areas within ED. Do we do separate channels, and then also having the ability to broadcast to all staff within that area? We're also working around some of ED has a shift between also the clinical work devices, is what we're calling them, and then the doctors that have their bring your own device, which will have the apps on there as well. So they have quite a strong mix in that space.
And I remember when you were preparing, you sort of split up your ICU. You had a red zone, which is where PPE was going to be worn, and you wanted to sort of limit the amount of people that had to go back and forth between the different zones. And can you sort of share how using diversity with push to talk has enabled you to do that?
Yeah, so we've been trialling the push to talk in those spaces because we are, I don't know if the best word to say is that we are lucky that we haven't had COVID patients in our secure areas. However, being able to communicate through those different barriers, especially with mobile phones, if you take a mobile phone in, then you have to take it out, then there's different cleaning processes. We've been using that channel system to be able to communicate inside and outside of those red and green zones.
Thanks,
so that's been quite good, yeah. Because the only other mechanism is picking up a phone that's attached to a cord that you need to stand next to the wall, and at times that just operationally is not possible.
Now, Sean, your staff are using these devices inside the red zone today. You know, can you tell me how Versity is worn with a PPE gear?
It's certainly something I never expected. So wearing full PPE, when we first evaluated the Spectralinks in ACT 18 months or 2 years ago, the belt clip was one of the most successful things that the clinicians love because it just grips onto your scrubs and you can go anywhere. What we've discovered in the last month since we've gone live is that there's nowhere for you to put it on a full gown. So wearing full PPE in one of our hot zones is generally a full gown, gloves, N95 respirator, goggles, and a shield. And usually you've got to put another plastic apron on as well. So you've really got no capacity to attach it to things. We are seeing people being very creative and inventive of how they're trying to stop it on. And we are also working with the infectious control people to understand a better way of potentially holding it around of a lanyard or something like that to keep it in that area, or a disposable belt or something, because the wrap around for your gown is just not supportive of that. So again, these are things that we've not experienced previously, but they're things that we're learning the more we have to go through, dealing with COVID. And the staff are finding ways of doing it.
And so they're wearing the devices on the outside of the PPE. And then in terms of communication, do they have to be cognizant of then holding the device close to their face? Are they using it in a speakerphone mode? How are they sort of operating it in that environment?
So we operate it from multi-factor. So we have, especially if we're looking in ICU, we have a Cisco handset inside the room. We have the mobile phone with them. We have the Spectralink device with them. So we've got a whole range of different things that we can utilize depending on the type of criticality that the person needs. If it is a hot patient and you've got all the doctors standing outside and a single clinician inside working through and doing the analysis on behalf of the doctors, then there's usually an open communication between them, which could be done via Spectralink or via the Cisco phone. It really does depend on how many people, if it's one to many or many to one, or what the noise is in the room. Like each time seems to be slightly variant, but the ability to have the option is absolutely amazing for them.
Okay, thank you, Sean.
Sorry, rather than writing backwards on the glass window, which was the alternative about a month and a half ago.
Bill, the US has also faced a massive challenge with its healthcare system and dealing with COVID. What are you seeing from your customers in the States? Were they prepared from a communications perspective to the challenge in their critical care environments?
Some were more prepared than others, but we have found that the awareness of communication is just that much more acute. And hearing Sarah and Emma and Sean talk about how they've deployed this and how they've worked around some issues, like I'm spinning in my head thinking of what kind of lanyard we can build for this phone, so that you can actually use it underneath your PPE. So, but certainly what we're finding is the ability for this to be clean, the durability that you heard about, is that, it's a tough environment. I mean, it gets dropped, it gets banged into walls, it needs to be clean. So not having your iPhone or your Samsung BYOD device that can't be cleaned, that doesn't have medical, when we say purpose-built, this was purpose-built for healthcare. It has medical grade resins. It's not even plastic, it's a medical grade resin with a Gorilla Glass screen, and you don't have to worry about it, getting any type of ingress of bacteria. By the way, you can clean it also in UV boxes. I don't know if you've seen some of that in your hospitals down there, but the ultraviolet light, you can actually put, people are buying these UV boxes and putting the phones and their masks and keyboards and their car keys and anything else, you can put it into this UV box. So we're finding that to be a big run in the US right now, with hundreds of hospitals now deploying UV as a cleaning methodology. But we've had customers contact us with some of these stand-up hospitals that are being built in convention centers or in tents outside, and they need a mobile device because they can't just wire phones we've had several customers, place really emergency orders just to have communications with their staff.
We're actually trying some of those UV boxes at the moment. So yeah, it's interesting you say that. Yeah.
Yeah, it's we actually simulated 3 UV cleaning processes per day for something like 2,000 days to see if anything happens to it. And but the only thing after about 2,000 days was those little grill marks like you put it on a barbecue. So, that's about
on the durability side. We've seen the clinicians, especially in a hot ICU, be absolutely hammering these devices. They are dropping them, they are smashing them together, they're throwing them basically in rooms, all sorts of stuff. Things I didn't expect, in all honesty, to happen. And these things are durable plus. Like, I haven't had any break because of that. It's a couple of lost configs, but I'm going to blame the MDM on that one.
Yeah, when we built the device, our testing, we actually drop it 78 times from 1.5 meters to a steel plate. So that in the US it's called the mill standard, and that's actually 3 times the mill standard for drop. So it can get broken. Trust me, nurses do have the ability to break things. I'm married to one. I get it. So, but yes, it is durable. It's good to hear, Sean.
And it's an important point. If you're going out to market for a device, make sure that you specify and put enough information in there to actually justify having a device that does it properly. There are a lot of vendors out there, when we did the market tests, that don't necessarily provide the same level or same capacity. Make sure you document your expression, your statement of work for the device. It's so important because you don't want to get the wrong product.
And Alan, if I can add another component that has come up lately in the States is around staff safety. And as you see on the diagram here is that little red dot on top of the phone. And I call it the staff assist button. Some people call it the panic button. But when you now have people who are working in environments where maybe they're the only clinician in the room because of their donning PPE equipment, their safety can be at risk, or all of a sudden they do need to get lift assistance right away or have trouble. So we're finding a lot more customers programming that red button as a staff assist button to call their buddy nurse, to call security, to open up a speakerphone for a full duplex conference call. So it's, again, it goes back to that purpose built and what we utilize that phone for. So whether I'm doing, moving of a patient, I need that, again, that lift assistance, or I am having a physical altercation with the patient, I'm able to press that button and get help.
Yeah, and I see that a lot as a requirement, especially in emergency departments and mental health units in Australia. Like, lots of customers really like not just having the red button, but the fact that if they get knocked over, the phone can even send out an alert if it's tilted at a certain angle, if someone's running, if someone's not moving for a period of time. They really like those alarm features. What I think I might do at this time, because I certainly asked you guys enough questions. We've got a larger audience here, and I'm keen to open up to allow some of those audience member attendees to ask some questions. So at this point, Craig, if I hand back over to you, and we can facilitate some questions from our attendees.
Hi, yeah, thank you very much for that, Alan. This has been a great discussion so far. We've got some really interesting questions that have come through, so I'll work through them. The first one is for you, Sean, particularly. Chris Mason says thank you for the handwriting tip. His handwriting's been terrible, but have you noticed any issues with latency, particularly for clinical activity with the device while in ICU?
No, not at all. We did extensive testing to make sure the Wi-Fi was going to be efficient for Epic, which is the EMR that we've purchased, and we've had no issues with latency on the Rover app at all, or with voice.
Awesome. Cool. And another question for you, Sean. When using the Spectralink device with the PPE, how are the staff using headsets? Are they using like Bluetooth headphones or anything like that, or is it just normally, or is it just a speakerphone?
So we've been doing a number of different things. Obviously, when you've got a face shield on, it's quite difficult. We've been exploring different types of products and both the ones that go around and earphones in, ones that we can tape to your ears. Like there's a set of different strategies that we've been doing depending on the type of ward. There's no answer really as a one case fits all. Each environment is slightly different in the way that they want to do it. Doctors, as opposed to clinicians, want to do things differently. Like there's a whole range of different things that we're doing.
Awesome, that's great. The next question, I guess, it would be for the broader panel. One of the earlier questions that came through was around the devices being LTE or just Wi-Fi, and I went back to the person directly and said that it's both. But can you speak to the use cases that you guys have used where people are using perhaps an LTE device over a Wi-Fi device, or is it just one or the other?
I can answer for ACT Health. So we did buy both for very different reasons. So if you're a critical code responder, we wanted to make sure that you never lost a call, never missed a message. So any of those roles would be using the 4G, the LTE. For the Wi-Fi only, it's more of the ones that are based on in the same space, in the same ward. We have 2 campuses for our hospital, so anyone that was travelling between the 2 would get one of the LTEs as well. So it was really a case-by-case basis on who was what you were doing in your role to decide how you were going to use it.
Awesome. And Sean?
The ACT, we did 80-20 rule. So we bought 80% Wi-Fi only and 20% LTE. We followed a similar sort of model in Melbourne Health, where we have basically one LTE to 8 devices, 8 Wi-Fi only is the general strategy.
Awesome. And Bill, I mean, is there anything that you've seen particularly in the States of how it's been adopted?
Primarily in the States, it's been Wi-Fi, but there's been a little bit of the LTE usage as well. And it's usually for when the clinician is leaving the hospital to go to maybe their medical office building down the street or across the way, is where they'll find the ability to utilize their 4G.
Awesome. And another question to the panel as well, and I guess this speaks to the project itself and how you kind of got it across the board. One of the earlier questions we got from Kieran Gay was, how do you justify the ROI? I mean, how do you look at it when you're positioning it? Because obviously it is a large investment. Do you look at it from an ROI perspective? Do you look at it from a safety perspective? Obviously with COVID as well, safety is a paramount, but how were those discussions had internally to get it across the line when cost did come up?
So from our perspective, and when you say ROI, what are you saying?
I guess for a return on investment from the business case, so what they would normally see from the funds that you've invested into the handsets, would there be something that comes out of it, or do you put it down to simply, this is something we need to do to ensure the safety of our staff moving forward?
I definitely think it's there's multi-factors in that space. So safety is definitely one very important aspect. There is also the fact, like for us, you know, the paging system is not the way in which we communicate in our private lives. So sending a number to then respond, we're finding that there is quite a lot of time spent trying to find out who called you and then what was the information that you required. So within healthcare, it needs to be real time to the right person for the right message to make the right decision. So that return of investment around now, instead of having an hour delay of communicating a message, it is more direct and more to the specific user. So I would definitely be saying that yes, there is the cost. There's the hardware cost in replacing whether it's pages, I-62s or general you know, if you went out and bought a fleet of smartphones, you've got that hardware expense, but you've also then got the ability, hot swap batteries is something that has been a very large component within our users and our clinical staff saying, oh, so I don't have to actually worry about charging my phone. So I think that's a multifactored area where you can't just singly look at a dollar value for the benefits that you would receive.
Yeah, I think we can probably all agree with that. It's more of a conversation, especially now. It's about health, it's about safety, it's about protecting people, not necessarily just a dollar figure. Sean, is there anything that you can add to that as well?
Look, again, the EMR project funded the initial supply of the devices, but we have seen a growth of another 100 devices, and we constantly get new areas going, well, we see this workflow and it worked really well in that workflow. So I would imagine that we'll increase them as well.
Sorry,
it's something that we don't usually measure. So how much time have we saved when we've communicated a message? So we're seeing numbers around phone calls and the reduction of phone calls when you can send messages. So that's another aspect that I would definitely suggest having in your benefits realisation.
And I guess
one of the other things, sorry, in the ACT, one of the other strategies of the CIO was really to try and reduce the number of landline phones and have a number that is dedicated to an individual. So he could cut back the number of Cisco phones on the desk, and the nurse actually has it, or the clinician has it, that number with them all day. So there really was, when we went out to market, the focus was really trying to align communications so that they were succinct and to a person, and to be able to expand on other technologies such as the communications.
Awesome. And I guess speaking again to kind of the time savings that people experience, how's it come with cleaning the devices between users? Obviously now with the devices needing to be cleaned, I guess as each person uses it, and that is at the front of everyone's mind, have there been any issues in terms of delays, or has the time blown out when it comes to stuff like swapping it over in terms of cleaning, or is there anything you can speak of from that regard?
So I'd like to suggest that we should have been cleaning our devices before, so there should be no difference. So there shouldn't be taking us any longer than it did before to swap a device over. I would suggest that perhaps as an ex-nurse, it probably wasn't happening as much. And now we've actually got a clear, you should clean it before you use it, clean it when you finish. It doesn't take very long to clean it. You wipe it over with the toughy wipe. It doesn't take any time at all. The fact that we're using, most of our devices are from a pool, so it's not, most of our people don't need to wait for someone else to sign out and clean it and things. They can just pick up a new device, sign on. We're not expecting a massive delay, and we're certainly not seeing that with the devices that we're using already.
Awesome.
And we're seeing very good sanitisation of our devices. We use Clinell Green, and it eats through everything, especially stickers when they put them all over it. And we've seen no detriment to the device at all.
Awesome, that's great. And if we look at the discussion now around delivering these devices to units and partnering with other companies, a question for the broader panel: how important is it to choose a partner who understands what delivering in a clinical environment means, rather than just a standard supplier who may not get what you're actually going through at the coalface? How important would that be, do you think?
I'd like to say it's extremely important. So we've been through this exercise, Emma and I, for a couple of months, not with Wavelink, with a different vendor, and healthcare is different. Availability, reliability, just even down to the basics of, I might have 2 roles that I'm doing today. So how do I make that work? So understanding that health setting, because yes, it's similar, but it is very different. Emma, is there anything else that you would add to that space?
I think that the engagement we've had with Wavelink has been really good, and using their experience from other places as well has been fantastic for us. And the partnership with them and Provider, things just got sorted out really quickly, like it's working really well, so it's been quite good.
Yeah.
From our perspective, we had to replicate what we did at Melbourne Health for another service, and because we pretty much replicated what we did at Melbourne Health for this other health service, I think Fook from Wavelink had it set up in 4 hours, and we had a full set of 15 devices that were working inside the hospital. There was no configuration to the Wi-Fi. It just worked out of the box.
That's great.
Actually, on top of that, Sean, so one thing we found which was interesting times for us. So from a standard project perspective, we got the devices in with COVID, but normally we would have in-person training for a lot of our super users and things like that. And because we were all in lockdown, we did not find any major impact to actually having that training service provided online. So that was quite important to us during the last few months, is being able to do that and doing it at different times, also understanding the different shifts.
No, and agreed. We got materials from Wavelink and I regenerated them into a Melbourne flavour, and we did that at handover in those wards, especially the hot wards, and actually sat with them and actually went through the process. And it was a 10-minute issue. As I said, people were so adapting to the mobile phone nature of the device. It was really simple.
Awesome. So we are on 1 o'clock. That's it pretty much for the questions. I'm throwing it back to the panel. Is there any last remarks or anything you guys wanted to say? Alan, Bill, over to you guys.
The only thing I would say is don't look at a phone as singularly just a phone. So also think about, what apps do I want to use on this phone and how do those apps behave? It's something that we overlook, but it will save you a few headaches along the way if you just start looking at them as a partnership around the app and the phone together.
Right.
I think it's really important to make sure you document your use cases, understand what you're going to use the devices for. If there are certain units, focus on how that unit operates, understand what applications are needed, whether it's kiosk mode or it's not. You really need to understand how you're going to deliver the platform and how you're going to maintain the platform as well in a BAU environment. It's one to get it out there. It's another thing to make sure that you can continue to maintain that product. And as things change, like Emma said, putting MIMs and things like that on it wasn't something we originally thought of, but to be able to deploy it and put it onto the device is really quite simplistic.
I think that's where it's critical to get input from the actual users and get out and ask them what's important to you in a device. What do you need? What's worked in the past? What hasn't worked in the past, so that they get input and you get the buy-in right from the start.
Great. Alan, over to you.
I think for me, just one of the key things I'd like to say is what I've learned in these environments is they're using our devices for multiple use cases, but something that Spectralink says, and I repeat a lot, is voice is king. And I think that Spectralink's voice quality optimization, the fact that it can deliver clear quality voice over a Wi-Fi network, Spectralink have been doing this before anyone else, and they do it better than anyone else. And you know, we've had customers that have tried other devices, and you know, they've said, yeah, it will just work for voice, and they've come back to us a few months later and said, you know what, got problems, it didn't work. I think that's really a key learning. Voice is absolutely king, especially in a healthcare setting. People need to be able to communicate clearly, understand instructions.
Awesome. Well, that has come to the end of the session. Thank you everyone for attending. Sarah, Emma, Sean, thank you so much for your time today. Obviously, it's a very busy time for you guys, so we do appreciate you taking the time. And Bill, thank you very much for joining all the way from the US. We hope you stay safe, and we'll hope to talk to you soon. And Alan, it's always a pleasure to have you on these events. For all the attendees moving forward, like we said, we'll send you an email with the recording and the handouts as well, so you can pass to your greater team. Again, panel, thank you so much for your time. This has been a really, really great discussion. Can't thank you enough.
No worries.
Thank you.
Thank you very much.
Take care, everyone. Talk soon. Bye.